Hey there, welcome to AMC PrepLab, and today we're going to talk about the topic of bronchiolitis. I have collected the various guidelines, and let's get into it. The word bronchiolitis can be broken down into two: bronchiole, that is a small airway in the lungs, and itis, meaning inflammation. This inflammation of the small airways causes an increased amount of mucus to be produced, which in turn leads to airway obstruction, air trapping, and reduced lung compliance. Coming to the etiology of bronchiolitis, it is a viral lower respiratory tract infection with the main culprit being respiratory syncytial virus. The others are parainfluenza, adenovirus, influenza, rhinovirus, coronavirus, to name a few. It affects infants less than 12 months of age. Remember this point as it can help differentiate between the respiratory diseases which have similar clinical features during the exam. These symptoms can also occur in children older than 12 months, but then it is not called as bronchiolitis. The peak severity of infection is 2 to 3 days after the onset of symptoms, and it subsides over 7 to 10 days. Now, how would the parents bring the child to the hospital? The child would present with cough, fever, difficulty feeding, and would be irritable. Apneic episodes may also be present. There are a few risk factors that can lead to more severe disease. These are chronic lung diseases, congenital heart disease, chronic neurological disease. If the gestation age is less than 37 weeks, as lung maturation might not have taken place properly, or chronological age at presentation is less than 8 to 10 weeks. The other risk factors are growth restriction, indigenous ethnicity, immunodeficiency, exposure to cigarette smoking, and Down syndrome. It is advised to admit these infants even if they have mild symptoms, as it will most definitely progress to a more severe form of bronchiolitis. Now, coming on to the physical examination, there will be tachypnea, use of accessory muscles, which is manifested as retractions, that is suprasternal, intercostal, substernal, and subcostal retractions. Bilateral wheeze and or fine crepitations, and hypoxia. Now, what are the investigations that has to be done? Well, bronchiolitis, since it's a clinical diagnosis and most children don't require any investigations, it can be done only when the diagnosis is uncertain or the child is deteriorating. There is no need of chest x-rays, blood tests, or swabs for viral PCR. Now on to the severity of respiratory diseases. This table is important and can help guide us through the management. Pause this video to read or take a screenshot. This is the treatment guidelines taken directly from the RCH website and a few points from RACGP. The two things that we look for is first, the respiratory status, and second, the hydration of the infant. In respiratory status, check if the child is persistently hypoxemic, which we can know if the SpO2 is less than 90% in room air. If yes, start supplemental oxygen at 2 liters per minute by low flow nasal prongs. Do early monitoring for moderate disease and continuous observation for severe disease. If the child has severe or life threatening illness, seek ICU review and start high flow nasal prongs or CPAP. Assess treatment response within 2 to 3 hours or earlier if unwell. If the child still has hypoxemia with SpO2 less than 90%, tachycardia, tachypnea, or an increased work of breathing despite 2 to 3 hours of treatment, consider high flow nasal cannula oxygen at 2 liters per kg per minute and titrate FiO2 to keep saturation above or equal to 90%. If the hypoxemia is mild and the patient is clinically improving, consider a longer trial of nasal prong oxygen. If the child does not have ongoing hypoxemia, titrate and wean oxygen to keep SpO2 more than or equal to 90%. We can stop oxygen monitoring when not requiring oxygen for more than or equal to 2 hours. Now we see if the child is improving with high flow nasal cannula oxygen. Improving means SpO2 more than or equal to 90%. Vitals and or work of breathing improves. and no significant apneas associated with bradycardia and or desaturation. If yes, then we can titrate the FiO2 to room air, making sure the SpO2 is above or equal to 90%. Trial of oxygen every 6 hours and recommence nasal prong oxygen if SpO2 is less than 90%. Cease high flow nasal cannula oxygen when stable in room air. If the child is not hypoxemic and has moderate to severe work of breathing and or has any of the risk factors earlier mentioned, consider a period of observation or else discharge home. Now the second thing is hydration status. If the oral intake is less than 50% over 12 hours or clinically dehydrated, commence NG feeds at 2 by thirds the maintenance state. Cease NG feeds when patient is able to tolerate 2/3 oral feed. If NG route is not possible, go for IV hydration. Use an isotonic solution with added glucose. Now coming to the drugs used. Usually, no drugs are recommended. Although RCH suggests that chloral hydrate can be given to children to reduce agitation in children with worsening respiratory distress, but use with caution in children with renal or hepatic dysfunction. RACGP suggests the use of bronchodilator trial if the child has recurrent wheeze. If there is improvement with bronchodilator therapy, then treat as asthma. Do not get confused with the other respiratory diseases such as asthma, pneumonia, or anaphylaxis involving the airways, as drugs given for these conditions should not be given for bronchiectasis. The drugs that shouldn't be given are adrenaline, hypertonic saline, antibiotics, and antivirals. Chest physiotherapy is also not recommended. Nasal suctioning should be done only superficially, if required, at the time of feeding. Saline nasal drops can also be given at the time of feeding if required. Consultation with the pediatric team is required if the child has risk factors for severe diseases, requires supplemental oxygenation, has less than 50% of normal oral intake, and is clinically dehydrated, or if the respiratory status is moderate to severe. Transfer the child if it is a severe bronchiolitis case, risk factors present, or if the oxygen required is more than FiO2 of 50%. Discharge when the SpO2 is more than 90% and feeding is adequate. So that's all about bronchiolitis. If you have any questions, please leave them in the comments. Thank you.